We're here talking about our palpation concept, so this is the second concept. So the first one was specificity is not the number one necessity, in brackets, movement is. Okay. The second concept, or the second idea, is that if you want to try to identify something more accurately, not perfectly accurate, but more accurately, is we know from study and we know from research that using multiple landmarks is the most appropriate way to do that. Now, considering that BMI is related with reduced accuracy. Now, when they say BMI, they may be speaking about increased subcutaneous fat, or they may be speaking about increased muscle mass. So instead of trying to follow a structure to identify something else, what we do is we can very easily go to a highly palpable structure in the midline or somewhere else, wherever we are, and move off of it, move away from it. So one of the things that is common in trying to identify the PSIS is using the iliac crests. Now, the iliac crests are a region where you can have, regardless of how muscular or lean a person is, you can have subcutaneous fat get in the way, you can have muscles get in the way of tracing the iliac crest. So what I would suggest is the easiest, most exposed palpable landmark is the sacrum. You can identify that with your eyes, just looking at the midline. You can palpate the sacrum, and then begin to palpate off of that. And you can identify the PSIS in an easier fashion off of that. So one way to do it is here, and you kind of come over off to the side, hand posture, and I can identify where that PSIS is, and I can identify where that PSIS is. But it's because I'm coming off of the central landmark, and I know that in relation to the central landmark, the sacrum, the PSIS, will be elevated. So as I palpate laterally, when I feel the elevated portion, I can identify it. Another way to look at this is something such as the Greater Trochanter. Now, people would try to find the Greater Trochanter specifically, and they're going to push through tissue. It's not a necessity. What I can do is broadly contact the region. My hand is broadly contacting the region, and I can do things such as push the patient into my hand until the harder mass, the bony mass, the Greater Trochanter, becomes more palpable. That's one way to do it. I can have the patient simply roll your leg in and out and let go, and then it becomes more palpable, so that's a way to identify it. I'm not trying to specifically identify it first. I'm going in the region. I'm deploying a broad sensor, and then I'm identifying it. I can go ahead and look anywhere in the vertebral column. If I wanted to identify the lowest lumbar vertebrae, I would again come off the sacrum. I would identify the sacrum, and what I would do is walk to the top of it and then go forwards. As it dips forwards, I'm going to know that the first bony mass that I identify is going to be L6, L5, or L4, depending on how that person is built. And we've talked about this. It's one of my kind of most common things to say with respect to the lumbar column is we don't know which vertebrae the lowest one actually is, but we know that it's there. And it is often highly obscured by subcutaneous fat, not usually by muscular tissue, but even in lean people it is often obscured by subcutaneous fat. So I'm moving from a known landmark to an unknown landmark. If I wanted to identify the region of T12 or the region of L1, what I would usually do is broadly contact the thorax, the rib cage. I would come to the lowest palpable bony mass, and I would follow that in. Now, I don't actually have to follow that in. If you see my hand, I can use a yoke hold, so I can move off the 12th rib, follow that 12th rib in just with that yoke hold. See, I can kind of move my hands around to identify where something is, and I know that as I come in, I'm probably at T12 and L1. Now, if this person has a supernumerary rib, a 13th rib, or an abnormal 12th rib, abnormally small, or any other abnormalities, I'm not going to be a T12. I may be somewhere else. But I at least know that I'm at the bottom of the thorax. I can say that much clearly. So again, what we're doing is we're moving from a known or multiple known landmarks, or a known landmark, moving from the known to the unknown. And that's what we're trying to do, move from the known to the unknown.